Thank you very much, sir. So very good evening and a warm welcome to everyone. And before I begin, I'd like to congratulate the organizers and also thank them for the opportunity. So I'm going to be talking on the Keynote 598 data and the update of that data, which we've seen recently. And also the role of IO plus IO combinations if you have a PDL1, when even in excess of more than 50%. So how do you actually end up making decisions for patients with advanced non-small cell lung cancer? Histology, targetable mutation, level of PDL1 expression matters as well. And then patient-related factors like preference and performance status, whether any history of autoimmune disease as well. You'll probably have to take all of this into account before you make a decision. So I think in a nutshell, this is how you would look at it. More than 50%, you're more than happy with going in with only a single agent immune checkpoint inhibitor, 1 to 49, a combination of IO plus chemotherapy, and less than 1%, probably that's where you would want to use an IO plus chemo or an IO plus IO. So this is how we've had it until now. So I think this is the ever-growing list of trials that have led to the approval of all these agents in the first-line setting. We're always talking about combinations. And I wanted to just focus on the last three trials, the Empower Lung 1, Keynote 24, and the Empower 110, which led to the approval of monotherapy, immune checkpoint inhibitors as monotherapy, be it cemiplimab, pembrolizumab, or atezolizumab, for anybody with a PDL1 of more than 50%. So we've come a long way from the approval of pembrolizumab in 2016 for only patients who had a PDL1 of more than 50%. Now in the current setting where we have three agents approved as monotherapy, which is pembro, atezo, and cemiplimab for PDL1 of more than 50%. So I'm going to quickly take you through the data of single-agent immune checkpoint inhibitors. This was the data for Keynote 24, which we have seen earlier as well. Again, a strikingly improvement in the median overall survival, which is doubled at 26 versus 13 months when pembro compared to a platinum-based chemotherapy. And this is cemiplimab, again, similar results. But again, the median overall survival hasn't been reached yet, but you can see that the curves are starting to separate widely. What about IMPA 110? Well, atezo is not to be left behind as well. And median overall survival, again, an absolute difference of close to 6 months with atezolizumab as monotherapy. And be it all of this in patients who have PDL1 of more than 50%. So this is what we've seen across the board. The response rates to the tune of around 40 to 45%. And again, the median PFS of around 7 to 8 months and median overall survival of close to 1.5 to 2 years. So this is again something that I wanted to talk about as well. This was again the data for first-line pembro versus chemotherapy. This looked at all comers, again with a PDL1 of more than 1%. And again, if you look at it in patients who had a more than 50% PDL1 expression on the TPS, the magnitude of benefit was definitely much higher. So even though it's approved across the board in patients who have more than 1%, I would say the magnitude of benefit is much higher when you have a higher PDL1 expression. What about combinations? Well, this was the first combination which was looked at, which was the NEO-EP combination, which was a CheckMate 227 study. And they looked at it both in PDL1 more than 1% and less than 1%. This was the 4-year overall survival update. And I think interestingly enough, I think this is one data subset where the magnitude of benefit was probably maintained even in patients who had a PDL1 of less than 1%. So it comes into its own in that setting. And now we have the data from the CheckMate 9LA as well, which looked at the addition of chemotherapy to at least for 2 cycles with NEO-EP. And there again, the results are strikingly impressive, even in patients who don't have a PDL1 expression or if it's less than 1%. And again, the treatment-related adverse events, well, we all thought that with the addition of ipilimumab or the CTLA-4, obviously the GI-related adverse effects was seen higher and our colitis is also higher. So this is what I'm going to really talk about today. Whether could you do a combination of an IO plus IO or the IAO combination in patients who have a PDL1 of more than 50%? And this was compared to only a single agent immune checkpoint inhibitor, pembro being the drug in this study. So baseline characteristics were pretty evenly matched as far as the age and sex and the performance status and the histology as well. Well, when you look at it, absolutely similar response rates, 45 versus 45 in the combination as opposed to the single agent. And absolutely nothing to separate both of these. So let's look at the overall survival and the progression-free survival as well. Again, strikingly similar. The safety reasons, well, again, we all know that the addition of an IO plus IO, well, any grade adverse events were slightly higher with the combination as opposed to single agent IO. So what did we conclude or take home from this study is that the addition of an IO plus IO in patients who had a PDL1 of more than 50% is definitely not beneficial. This was a negative study, and hence probably a single agent IO is probably good enough in this subset. You don't need to add another IO if you have a PDL1 of more than 50%. And this was the checkmate 9LA, which I was talking about earlier as well, where the addition of chemotherapy for 2 cycles and the magnitude of benefit was maintained across all subsets, be it more than 50% and even less than 1% as well, which is what is strikingly beneficial about the study. And this is the updated overall survival. Clearly, you can see here that even less than 1%, the curves are still starting to separate. And the onset of adverse events obviously higher in the first 2 cycles, because that's when you're giving chemotherapy as well in combination with an IO plus IO. But well, it's not always all hunky-dory for IO plus IO combination. This was yet another negative study in the first-line setting. Durva plus tremelimumab, the Poseidon study, which was presented at WCLC Congress. Again, the combination actually did not seem to improve on just single-agent Durva. So when you look at it, if you have a high PD-L1 expression across histologies, well, single-agent immune checkpoint inhibitors are good enough, and we have 3 approved agents, pembro, atezo, and cemiplimab. Median PFS of around 8 months and median overall survival of 1.5 to 2 years. So this is how I would put it as my working algorithm as well. So if we have a high PD-L1 expression, especially if it's more than 50%, you could absolutely go ahead with single-agent immune checkpoint inhibitors. But if somebody's got a high symptomatic tumor burden, or if you want a rapid response, then you could look at adding chemotherapy even in that subset. So I think that's probably the take home. With that, I'll conclude and say thank you all for your patient listening.